Thanks, Bob, very much indeed. And good evening, everyone. Delighted to welcome Professor Richard Sullivan for this topic about let's talk about prostate cancer. Can I just remind you that, well, in fact, 2023, I thought I had it myself, and it made me recall a remarkable man and a remarkable presentation, Phil Sampson, who some of you may recall. He was a very old friend, but he also a founder member of the Leaders Club. And it's 18 months ago since Phil actually died of prostate cancer. And a year or so beforehand, he did the most remarkable, moving presentation called Dying Well. And I know he had spoken to and had counsel and advice from the remarkable Richard. And that's one of the reasons that I came back to him. You'll recognize Richard occasionally from the Ukraine presentations. He's an eminent consultant. The details, of course, will be on the information I've sent out previously, but we couldn't have a finer man to talk about this subject. And do feel free to ask the sort of questions which concern you. I certainly will myself, because before talking about off camera, for many men of my age, the challenges of one's bladder are ones which endure day after day. Anyway, more of that later. So may I invite Professor Richard Sullivan to give us some more information about the issues and challenges of prostate cancer. Richard, over to you, please.
That's wonderful. Thank you very much indeed. Splendid to be here, ladies and gentlemen. I'm going to preface what I'm going to say this evening by recognizing that this is probably quite personal to many of you on the call today. I'm very happy to have discussions, obviously, in open forum at the end of this, but if there are specific issues that you want to raise or discuss, please do feel free to email me, and Stephen and Bob have my email address. And also just to say that I'm going to present some slides, mainly because this is quite a difficult topic to wrap your head around, and it will give you a chance maybe later on to sort of review the evidence. And it's really going to be focused on this really thorny issue of prostate cancer population screening for the English NHS and for more broadly United Kingdom. But before that, I want to really start by orientating everybody to the prostate and just to give you a very broad outline of kind of modern treatment where that's concerned, because it is germane to when we talk about prostate cancer screening, because in a sense screening makes men enter specific pathways. So with that in mind, I am going to share my screen now, and hopefully this is where my surgical technological competence, I hope, holds out. Firstly, this is a little bit of anatomy. You know, as a surgeon, one always enjoys a little bit of anatomy. The prostate is an organ, walnut-sized. It's wrapped around the urethra, and as you can see, it's in very close proximity to the bladder, and at the back, the rectum. Why is that important? It's important because of the side effects that one develops through the major modalities of treatment, whether it's surgery or radiotherapy. It's a fascinating organ. As you say, it's there as a sexual organ. It produces and secretes fluid, which contributes to the ejaculate and enhances fertility. So that's the role of the prostate. There are remarkable diversities around the world in terms of size and also makeup. It's interesting, it's one of the organs that has one of the highest levels of what we call oncogenic transformation. In other words, creating cancer out of it, for a whole variety of reasons I really don't want to go into at this moment. The risk factors for prostate cancer are, in a sense, have been known for nearly 30 years now. Firstly, it's just growing old. And I'm afraid to say to the men here that you weren't biologically designed to make it much past 35, 40 years old. Evolution created men to make it to a certain age and then get rid of them. Women, far more important from an evolutionary perspective. So when you get older, your likelihood of prostate cancer increases. And the general rule of thumb is when we talk about this in medicine is if you take every 85-year-old man and have a look inside their prostate, about 85% of them will have some sign of prostate cancer cells within their prostate. They will obviously live and die with that prostate cancer. It will never become important, but that's the relative rule of thumb. Blood relative with prostate cancer is a high risk factor. We know this from twin studies. We know these from other forms of genetic studies, that if your father or your brother had prostate cancer early on in life, you are much more likely to get it as well. And there are complex genetics behind that. We also know for men of African descent, your risk of prostate cancer is much, much higher. And they are a particularly difficult to reach and vulnerable group within the UK and generally across Europe. We also then have very, very specific high impact mutations, these things called BRCA and Lynch. But BRCA people might know about because it's involved in breast cancer, but it's also involved in prostate cancer. So these are specific genetic defects, and about probably around 10% of men with prostate cancer have those problems. But this is generally the risk factors. Other risk factors more generally, we can talk about being overweight, obese leads to increased risk. We think certain diets might increase your risk. Consistent and constant prostate infections as well. Anything that's pro-inflammatory. How do our patients present? Well, it's very, very variable. Many people have what we call lower urinary tract symptoms for a long time before they present. That's often, very, very low grade. The need to pee more often than usual, the feeling that you're not emptying your bladder. There's a sudden urge to pee. Some men just simply feel unwell, achy, tired, lower stomach pain, for example, very non-specific. Interestingly, most individuals are picked up by their significant other halves who insist that they go along and see their GP with these symptoms because they're now getting up 3, 4, 5 times a night. Once you're into the symptoms of bone pain or significant weight loss, the likelihood is you've probably got advanced prostate cancer or advanced cancer of other sorts, but mostly prostate cancer. Men are also picked up through general PSA screening or well-man checks through the private and the public sector, and also through this kind of anxiety peer review, that somebody who's been diagnosed with advanced prostate cancer, you rush off to get a test. Also, it's interesting when a lot of men who come into the NHS for other conditions, we often pick up incidental findings on imaging or histology because they're in for one condition and we pick up cancer with another test. So there's a range of presentations here. So what is prostate-specific antigen? Well, it's a protein. It's produced by prostate cells. It is very organ-specific. No other organ in the body produces this particular antigen which goes into the bloodstream. But people often say, well, obviously an elevated prostate-specific antigen must mean you have cancer. And that's not the case. Your prostate-specific antigen can be raised with something called BPH, benign prostatic hypertrophy. This is very common in men. This is where your prostate enlarges, becomes hypertrophied, and essentially what you have to have with that is often have to something called a transurethral resection of the prostate, an operation to reduce the size. That can cause it. Prostatitis, infection of the prostate. If you've got urinary retention, if you've had something called a DRE, a digital rectal examination by your doctor, if you take a blood test afterwards, your PSA will also increase. And on the right-hand side there, that table just essentially shows you the levels in nanograms per milliliters of your prostate-specific antigen and the cancer risk chance. So we often say, 3 to 4 nanograms per mil, about 26% of men will have cancer. By the time it gets over 100, about 100% of men are likely to have cancer, and often these men will have had advanced cancer as well. So the PSA test is not completely specific to cancer. That's the point I want to make. And for those of you who don't understand staging, we also then, once somebody's prostate-specific antigen is raised, we'll then take a biopsy of the prostate, and particularly these days something called a template biopsy, where we take a number of cores, because you can imagine in a round organ you've got to look for where the cancer is. And then we also use imaging and other forms of techniques to understand at what stage you are. And you'll see there the staging from stage 1, which is very small, localized in one area of the prostate, all the way through to stage 4. And stage 4 really is what we call metastatic or advanced prostate cancer. That's where the cancer has got out of the prostate, it's got into the lymphatic tissue, into the bone, and has spread across the body. And then those different stages. Staging is really crucial because staging really tells us, A, what your prognosis is going to be, and secondly, what sort of treatments we're going to offer you. Now, treatments. When I started 30 years ago, the treatments were relatively straightforward. There wasn't much, to be honest. We operated, there was basic radiotherapy, and there was basic chemotherapy. These days, there is a very large range of new techniques. When we talk about surgery, we've probably heard now, we're using robots, the Da Vinci robot, to operate. We have a range of radiotherapy options now. And importantly, within systemic anti-cancer therapies, that's chemotherapy, that has expanded massively, and including antigen deprivation therapy, and also new things like kind of what we call radioligands. That's where we deliver radiotherapy to the prostate. And again, I'm not going to go into any detail now because this becomes very, very baffling. But there is a huge range of options available from the early stage all the way through to the advanced stage now. And that has actually dramatically improved outcomes for men now who 20, 30 years ago, if you got advanced prostate cancer, you were gone very quickly. Nowadays, it's much, much better. If you look at the 5-year survival, even with very advanced disease, it's 40 to 50% now in the good centers with these range of treatments. And I think this is really important because, when I showed you those levels before, you've got to understand that obviously 3 out of 4 men with a PSA of 3 nanograms per mil or less will not have cancer. But if you have a low PSA, and we've seen this before, it doesn't mean you're completely clear. You may still have prostate cancer, which will appear later on. For early disease, the outcomes are excellent. 10-year prostate cancer specific outcomes are 95%. You notice the way we put prostate cancer specific survival, because obviously this is a disease of age. Many men will die of heart attacks, etc., but before they get to this level. In other words, that the prostate cancer actually kills them. So that's why we use prostate cancer specific survival. So that, in a nutshell, is the broad brush of how we treat. What's changed radically recently, of course, is you'll be aware of this, where Sir Chris Hoyle will be very familiar to you all, came out revealing that he had been diagnosed with terminal cancer and when this was actually reported, he'd been living with this for almost a year. And this has triggered a huge wave of activity and activism, particularly around prostate cancer screening. I should add, in parallel, Prostate Cancer UK and other organisations have also been driving very much the prostate cancer screening and outreach to men of African descent across the UK as well, because again, their outcomes are pretty dreadful because they present late, they have much higher risks, etc. So these two things have sort of conflated together. There's now an all-party parliamentary group on prostate cancer, and there's significant heat and light and drive about putting together essentially a major screening program for the NHS. But I'm going to enter a world of caution here about population screening for prostate cancer and separate off a national screening program and what's required for that from ad hoc PSA testing for men who are at high or higher risk. Now, the evidence for prostate cancer screening is really quite complicated, and what I've tried to do is simplify this into sort of levels that I hope people will understand. There have been really big studies of this, both in the US and in Europe. In the very early 1990s, this is one of the first ones that came out. It was called the ERSP study. As you'll see, this is an enormous study, nearly 162, whoops, I'm going backwards there, 162,000 men between the ages of 55 to 69 years old were pulled in for this screening trial. And as you'll see there from the study, the planned screening involved a PSA assessment every 4 years. And basically, if the threshold of 3 nanograms per mil or greater was reached, in other words, you had a PSA of 3 or more, then a biopsy was considered necessary and you were given a biopsy. The control group here was not offered screening as part of the trial. And when we analysed this data, what it showed is we needed to invite to screening to prevent one prostate cancer death, either 781 men at 3 years or 570 if you screened all these men over 16 years. Now, why is that important? It's important because those numbers are enormous. You have to screen very, very large numbers of men to really prevent a death here. The next study that was done was, if I can get us on to the next one, good, was an integrated study of prostate, lung, colorectal, and ovarian. They were all put together into one group, and there was a multi study site. Again, 76,000 men between the ages of 55 to 74. As you can see, the age range has gone up here. And the screening this time was much, much more intense. So it was 6 annual PSA measurements and 4 annual digital rectal examinations. The threshold was set higher, but what we found, of course, with this trial is PSA testing was also quite common in the control group, and that was a big problem, because if the control group are also going after the screening test as well, out of study, it contaminates the control group arm. And unsurprisingly, this massive trial found absolutely no difference for the screening test. The UK, because of this, also decided to do its own trial. And again, nearly 500,000 men, the age range of 55 to 69, and they were invited for a one-time only PSA screening. Again, the level of cutoff for actually intervening and actually doing a biopsy was around 3 nanograms per mil, and they were followed up for 10 years. And the rate ratio here was tiny. Basically, what we found in the UK screening is prostate cancer mortality did not significantly differ between the groups. And what this all led to was a major review by the US group. And this is important because, in a sense, the US has kind of been the leader in looking at prostate cancer. And when they looked at all the data from all those 3 trials, put about 6 other different trials as well, putting together, what they said that for the US system, for 1,000 US men between 55 and 69 years of age being screened every year, you would prevent deaths from prostate cancer in about 1.3 men in 13 years after initial screening. And essentially, remarkably, the US task force basically said this just wasn't worth it. We're just not preventing enough deaths by doing population screening. So this is where the population screening basically ended. And I think what's really important to understand is here that there are harms here. We have false positive PSA results here. Screening results in substantial overdiagnosis. In other words, you diagnose men with prostate cancer that would never otherwise go on to be life-limiting in any shape or form. And the estimates are about 23 to 42% of prostate cancer cases detected by screening were overdiagnosis. Now, if that wasn't enough, the British also waded in and decided to say, look, okay, let's just assume we put together a screening test and it reveals an elevated PSA. What should we do? Well, the screening tests, obviously, in the previous CAP study, about 77% had what was considered to be grade 1 clinically insignificant disease. So these individuals, along with others, were randomly assigned to having your prostate removed by surgery, prostatectomy, having radiation therapy, or something called active monitoring. That is where you have serial PSA tests going forward, and if the PSA starts to increase, you go straight for a biopsy. And as you'll see there, the prostate cancer mortality, irrespective of group, showed no significant difference between the groups. And this was probably one of the most important studies in saying to the British public at the time and to the British policymakers that going for population prostate-specific antigen screening with or without digital rectal was simply not worthwhile. Now, this is really rather important here. We have a number of major ongoing trials at the moment because the jury, as you can imagine, is really out. There's lots of new tests coming around. There's lots of new imaging modalities coming out. And without going into any details here again, because these are deeply esoteric and complex trials, there are now something like 6 to 7 major international trials being looked at in Sweden, Finland, Germany, a couple in the UK, and one big international one. And again, what we're trying to do is work out who are the men with the kind of tiger prostate cancers that we really, really need to put into a screening program, and which men can we say, we're not screening you, you've got what we consider to be the pussycat types of prostate cancer, we're going to leave you alone. But all of these are ongoing at the moment, and none of these, incidentally, have reported. So we're really in a situation at the moment that we don't really know how to best inform men about the potential advantages and disadvantages of screening, because we just don't know how to approach this. We don't know what the optimal prostate-specific antigen cutoff is. We don't know what the optimal start or stop ages is. We don't really understand the diagnostic results from repeated screening rounds. And of course, most fundamentally, right at the bottom is population screening using prostate-specific antigen or whatever test is inherently super complicated, and it costs a great deal of money. So it really has to be worth it for something like the National Health Service to pick it up, particularly when we've got so many demands now on health services, money, and also particularly within cancer on so many other types of screening modalities coming along, like lung cancer, for example. So with that in mind, I'm going to come to this conclusion, which is you'll hear a lot saying we need a population-based screening program. We simply don't have sufficient evidence to recommend any form of formal population-based screening. I think in 3 to 5 years, I think we will have a better idea of whether a combination of looking for prostate-specific antigen, doing novel imaging with magnetic resonance imaging, biopsy, etc., in high-risk populations is potentially of value. What really matters at the moment is clear pathways for men with symptoms, and also clear counselling for men who either want an ad hoc PSA test, or they have a high-risk ethnicity or family history. And I think the outreach around that and improvements around that would really pay dividends. And I think at the moment we're being kind of having these two issues conflated together when they're very different. So with that, I am going to stop and hand back to you, if I may. Thank you very much indeed.
Thank you.